Sorry, thank you very much, Sotirios. So it's 6. So welcome to everyone. Welcome to the EuSoMII 2025-2026 monthly webinar series. And I'm Alessia Guarnera, and today I will have the pleasure to moderate this great webinar together with Gennaro. So today the webinar is centered around AI in neuroradiology, dementia imaging, and we'll have the pleasure to ask Professor Sotirios Bisdas and Professor Stenaler. So why dementia? Dementia is a critical condition. We know that the prevalence is expected to increase progressively, also partly due to the population aging. So AI may represent a valuable supportive tool, but which ways and which are their real clinical impact? This is one of the key questions we will ask our speakers today. So it is my pleasure to present our first speaker, which is Professor Sotirios Bisdas, who is a neuroradiologist and academic leader specializing in advanced neuroimaging. He currently serves as director of the Department of Neuroradiology and Advanced Neuroimaging at Athens Medical Center, and is the professor of radiology and neuroradiology at the European University of Cyprus, while having an academic affiliation as professor of neuroradiology with the UCL Institute of Neurology and University of Tübingen in Germany. So his research focuses on advanced MRI techniques, quantitative imaging biomarker, and AI-driven imaging analysis from brain tumors and neurodegenerative disease. He currently serves as neuroradiology section chief editor in two radiological journals. So, Professor Bisdas, thank you very much for being here. It's my pleasure to introduce you.
Thank you very much. Good afternoon. Thanks to the EuSoMII and the ESNR for organizing this webinar. And over the next 20 minutes, I would like to take you through where AI sits today in dementia imaging, what is the state of the art, what is hype, and where the next algorithmic developments are taking us. I will deliberately keep this technical. Sven Haller will give you more clinical aspects on AI in dementia imaging. And here the audience, I understand, is mixed neuroradiology and AI informatics focused. So I will pull out the architectural and methodological details that matter here for the clinical translation. There are 4 learning objectives today that I will keep coming back to. The structure is deliberate in the meaning that each block moves us a step further along the patient journey. I will start from segmentation of an individual scan. Then I will move where AI helps us with a differential diagnosis, how AI influences and shapes the scanning protocol, particularly in the hybrid PET-MRI environment. And finally, I will touch on prognosis. And prognosis and therapy monitoring are very important nowadays in dementia imaging. The thread now running through all of them is the same. AI is not longer just a research curiosity in dementia imaging, but it is a necessity. And it has crossed now into routine clinical workflows, and we need to understand the algorithmic substrate of AI in order to trust the output, in order to have transparency. And as neuroradiologists or anybody who works in the dementia with dementia patients, sometimes to override the AI result, we need to recognize when the model performs well and when the model is pushed outside its training distribution. I will not go into basics like CNNs or transformer architectures because I assume you have seen that before. Now, before getting into the algorithms themselves, let me make the case for why the AI in dementia imaging is not anymore a niche conversation. First of all, globally, there are 55 million people with dementia today, and this figure will rise to roughly 139 million by 2050. And interestingly, this growth will be more tangible in low and middle income countries. About 3/4 of dementia now are underdiagnosed, and there is actually a much cited paper of 40 patients with behavioral variant from the temporal dementia, where only 10% of the MRI reports actually mention the diagnosis, despite an obvious atrophy pattern. Now, four forces are pushing AI from the research environment into the clinical workflow. The first is the arrival of the anti-amyloid immunotherapy. Here we have the two players, the two drugs, lecanemab and donanemab, which now create or help creating a structured imaging pathway with both eligibility, screening, and serial monitoring for area surveillance, and also to define the volumes of dementia. And this, of course, defines the volumes of dementia MR. The second is the updated ATN framework, which is the new biological staging system. And here we have a direct embedding of diagnostic criteria into this. So imaging interpretation has to be reproducible and quantitative. So last but not least, the amount of subspecialty neuroradiologists has not kept up with demand. So we need AI to help meeting this demand. And the four, which might sound counterintuitive, is that despite the rise of plasma biomarkers, this imaging has not been displaced. Actually, the rise of these biomarkers like p-tau 217 has shifted imaging's role towards topographic localization and individual prognosis. And we will see more about this in a minute. So let's have a quick look now at the framework. So there are two AI-driven contributions that we should hold in mind for the rest of the talk. The first is the ML-derived structural metrics, like the AAD Resemblance Atrophy Index. AAD-RI called is a model that compares an individual's brain to AD typical atrophy, and these technique outperform single volume measures like the hippocampus, or even outperform plasma NFL for 4-year cognitive decline prediction in patients with amyloid and tau positive pathology. The second is the unsupervised deep generative models, where actually we have variational autoencoders and GANs, and this, when they are applied to imaging, have started to expose AD subtypes that we cannot detect them by eyeballing. So for example, two newly defined AD subtypes is the diffuse Alzheimer's disease phenotype with widespread cortical atrophy, and the MTL AD phenotype, which is the medial temporal lobe atrophy. And here we see that the whole diagnosis is shifted. We do not anymore work with the patterns that we know from the textbook about Alzheimer's disease. New things are coming up. So the takeaway here is that imaging is just it's not longer just a rule out, disease or not disease, but it reveals traits of disease, subtypes of disease. And this is why it helps later for the precision medicine and the precision treatment. The MRI volumetry is the first thing where AI made a lot of progress. And this is actually what we know now as the mature deployable layer of dementia AI. The pipeline, I'm sure many of you know, is conceptually simple. We take a 3D T1 image series, we pre-process for bias and skull stripping, and increasingly that it is itself a deep network. Then we feed through a 3D unit, that's the state of the art, or a 2.5D view aggregation CNN. And at the end, we have a parcellation. And this parcellation is compared to an atlas of typically 100 to 130 structures. And the output is volumes referenced to normative database and expressed as Z-scores or percentile bands. The four tools that you will encounter in 2026 when we're talking about MRI volumetry is the Free Surfer DL, which is also called Fast Surfer, is a one-to-one replacement for the classical pipeline. We have the same atlases, the same metrics, but the runtime drops from 6 hours to about a minute on a GPU. We have the SynthSeg from Alessia and colleagues, which is an interesting approach because it is trained on synthetic images with random contrast, and it is therefore agnostic to whether you give it an MP-RAGE or FLAIR or a T2 flex sequence. And this makes it unique because it is now suitable for retrospective work or for harmonizing across scanners. The third is the AssemblyNet from Koop's group, which actually is an ensemble of CNNs across overlapping patches. And here the group has created a new approach and has coined the term lifespan tree framework, which I will show you later. And of course, we have a number of FDA and CE cleared commercial engines, Icometrics, Quantip, NeuroQuant, Mediair. I will not go into details about that, which are actually mature, and now they are embedded in clinical PET MRI workflows. However, the caveat is always the domain shift, and this is probably the single most important point. A model that achieves an excellent dice score, more than 0.95, may drop up to 10 points in your community hospital at 1.5 Tesla. And this makes imperative that we need always a local validation before we go live with this software application as a clinical service. The concept now of brain age has been around for over a decade. First, it was presented in the original Franke and Gasser papers, but we have now two recent advances that have moved it from a research curiosity to a clinical biomarker. On the left, I have plotted the concept. Essentially, you train a CNN on tens of thousands of healthy MRIs to predict chronological age from morphometry. And then you go to the patient level and you measure the so-called brain age gap. This is the difference between the predicted and the actual age. So researchers have published a 3D CNN ensemble trained on more than 30,000 healthy subjects. And when we apply this technique to real life, we have achieved a mean absolute error of 1.88 years on a young population and 3.83 years if we apply that on the elderly populations from the population from the UK biobank cohort. So you may find it accurate or inaccurate, but this is where now the benchmark is, and we have to work with this accuracy benchmark. The interesting now algorithmic step on the right is the lifespan tree of brain anatomy, what I mentioned before. Here, instead of having a single global brain age, we compute structure-specific age trajectories. So these are derived from 124 brain structures across the lifespan. The next step is to use nonlinear dimensionality reduction for every patient in order to embed the imaging phenotype into the branches of a tree. Each branch corresponds to a disease trajectory. Healthy aging, Alzheimer's disease with medial temporal predominance, frontotemporal dementia, Lewy body dementia, PSP, and so on. The classifier then asks, to which brand is this patient closest to? So you understand that it is easy, it is interpretable, intuitive, and crucially, it can capture more than one pathology, because we have a significant amount of patients who have coexistent concurrent pathologies. So before that, we had disease versus control. Now we can have multiple disease, and we can visualize the burden of each disease according to which branch the patient is closer to. So finally, one important thing is, because these algorithms actually take into account more than 120 different brain structures, we can see any systemic cortical thinning before it is visually apparent on the scan. So in other words, AI provides us a high resolution metric ruler that we can put it across the cortex in the whole brain. Now, after talking about volumetry, let's see how AI influences the FDG PET differential diagnosis. So we have the 4 brains here at the top. The AED shows in a classic way bilateral temporoparietal and posterior cingulate hypometabolism, and that's our reference pattern. We know that from the textbooks. The DLB takes the same posterior signature, but extends it into the occipital cortex. And here, the occipital cortex is the key discriminator. The behavioral variant of the FTD shows frontal hypometabolism and often asymmetric. And finally, the PSP and CBD involve the midbrain and frontal lobes. As I said, these patterns are textbook, but in practice, you know very well that they overlap, particularly in mixed pathology. So mixed pathology is what we can call now the elephant in the room. Up to half of the DLB cases have coexisting AED pathology, and clinical heterogeneity makes pure pattern recognition unreliable. If we also add that there are well-documented misinterpretation rates of FDG PET in the community, then we see that it is obvious that we need AI assistant. There is a publication recently published with 277 participants split across AED, DLB, and mixed and healthy controls. The authors used a 3D CNN with saliency map interpretability, and the result is very important. We show that there is very high specificity across 4 classes, from 0.85 to 0.93. But sensitivity for mixed pathology is only 40%. That tells you that the model is conservative. So when it commits to a class, it is right? That's the right thing, correct. But it cannot reliably flag the mixed cases without additional input. And which could be this additional input? This additional input is an MRI. So we show that FDG PET is not sufficient alone. Now AI will bring MRI into the recipe. So now, when we have, let's say, when FDG PET alone plateaus at around 90% in the binary classification AD versus control, where can we get the next 5 or 10 percentage points? By now fusing the AI and the PET. So there are 3 architectural families for this fusion. The early fusion, which actually concatenates the modalities at the input. So for a structural MRI plus FDG PET, it means stacking the two images as separate channels and feeding a 3D CNN. This is a simple approach and captures cross-modality interactions, but it loses modality-specific features. The intermediate fusion is currently the dominant strategy. Its modality has its own encoder, typically, again, a 3D CNN, trained on this modality alone. And we have also the latent representations, which are merged using either concatenation, attention, or cross-attention transformers. There was a recent systematic review which covered 66 studies, and this systematic review identified the intermediate fusion as the most popular and the best performing approach because it has the key advantage that preserves modality-specific learning and while still allowing the model to learn by cross-modal relationships in the bottleneck. Now, the third architectural family is the late fusion. The late fusion offers independent classifiers per modality and ensembles their outputs. The advantage is the robustness of the technique when one modality is missing. And to be honest, that's a very common clinical scenario. Now, let's have a look on the right. This is the performance ladder. Let's assume, according to the published literature, that we have an ADME-based diagnostic model of 92.5% accuracy for AD versus controls, so this binary task. Then an MCI to AD conversion prediction reaches an AUC of 0.92, and the best published fusion architecture can push it a little bit higher, up to 0.95. And these are the headline numbers we have currently achieved. Now, again, I will raise the attention for the caveat, which is very critical, that these self-collected single-center datasets, they may reach 95 or 96%, but their generalizability is limited because of small sizes and inhomogeneous scanning parameters. So talking about now scanning parameters, let's see the role of AI in shaping the hybrid PET MRI protocol, which I consider is state of the art and should be pursued if a hybrid PET MRI is available. The hybrid PET MRI is intrinsically well suited to dementia patients because it offers a comprehensive workup and can fit it into a 20-minute scan. Well, the PET data is acquired in list mode, and the patient has simultaneously the MRI sequences. You have the timeline here, how it looks like. And when the patient gets up, you have FDG or amyloid PET and structural MRI for the ATN framework classification. Now, the benefits are substantial. One visit is huge for these patients who depend on caregivers. There is intrinsic co-registration, which eliminates registration errors. If you're reading that on a separate PET or MRI workstation and you do retrospective fusion, the radiation dose drops to about 20%, and which is also here crucial for the AI angle, is that the workflow naturally produce a structured, standardized data set where every modality is aligned. And this is the ideal material to feed into our AI tools. When we talk about AI in dementia imaging and the imaging protocols, there are 6 places where AI is genuinely changing how a PET MRI dementia scan is done in 2026. The first is the deep learning attenuation correction. So there was historically concern about the inaccurate attenuation correction in PET MRI. I can still remember when I first used a PET MRI scanner back in 2000, I think it was in 2008. It was one of the prototypes available at that time. We had a lot of concerns, very serious concerns about that. Now, these concerns are essentially resolved because the GANs and UNITs can generate a CT equivalent attenuation map from a short Dixon sequence or from a zero echo time MRI sequence. Then the second place of where AI thrives is the data-driven motion correction. This is critical for this population because the least mode PET combined with MRI navigators feeds a neural network that estimates frame by frame the motion correction and realigns them retrospectively. So no rescan and fewer artifacts. The third is dose reduction, where we have CNN denoised low count PET reconstruction, preserving, however, the diagnostic quality we need, and allowing us to reduce the injected dose by 3/4. We have accelerated MRI. You know that pretty well, compressed sensing, deep learning algorithms. So we can achieve 40% faster MP rates and flare sequences, and this both time can be even be spent on a second PET tracer in the same session. We have the synthetic MRI contrast when the protocol has to be cut short. For example, in a follow-up ARIA scan, the networks can synthesize the missing contrast from what has been acquired. And the sixth domain is the joint PET MR reconstruction with MR anatomy. This is used as a Bayesian prior to the PET reconstruction loop. So sharper PET here, less partial volume blur, and this is particularly important if we apply the centiloid grade amyloid quantification. Now, considering the previous breakthroughs that I just mentioned about AI, let's expand now a little bit our capabilities. Diagnosis tells the patient and their family what they have, but prognosis tells them what comes next. And this is very important because until recently, neuroradiologists were not asked the prognostic questions. However, they will start asking us about prognosis because the clinical trials need enrichment. There are the amyloid therapies which need staging, and the patients want to know. So the next two slides will cover the main two algorithmic substrates for AI-driven prognosis. These are the spatiotemporal staging models and the connectivity-based predictors. Let's start with the spatiotemporal staging models. The simplest version is the sustain, which is the subtype and stage inference. Conceptually, this is a hidden Markov style model that takes cross-sectional data from a heterogeneous cohort and enforces both the order in which biomarkers cross abnormality thresholds and the existence of distinct subtypes. So what here is the take-home message is that you do not need longitudinal data per individual. The model recovers the trajectory from population variability.
Sorry,
so I have, I'm sorry?
Can you go to the conclusion?
Yes, I will jump to the conclusion. I will go very fast through this. Here is where AI staging takes a single scan and converts into a position on a trajectory. And we can tell that without having priors. The second prediction is the connectivity-based prediction, where here the default mode network is the principal. And because we know pretty well that it is disrupted in Alzheimer's disease. And using the connectivity and not only the simple connectivity metrics, but how the one area of the brain connects and behaviors compared to the other, we have actually a signature, which is very well correlated with the risk for AD. And this is actually shown in a UK biobank study. I will not talk a lot about ARIA because I think Sven will talk about that. However, I will talk about is how ARIA how AI fits in the ARIA workflow. The first is we can acquire the conventional FLAIR and SWI. We will do auto segmentation. We will detect any changes compared to the previous scan. And we will apply scales for an automated derived severity score, the so-called BARC-E and BARC-H grades. And all this will be fed into the decision algorithm. So the limitations. The first is the generalizability and harmonization, which are still the dominant problems. The synthetic data augmentations need some special attention, and they can be used in case that we have not a huge training data set. We need the foundational models. These are the obvious next architecture for large self-supervised networks. We will have multitask networks that predict volumetry, brain age area. All this will, I assume, be embedded slowly in the next clinical software versions. And to wrap up, so I tried to show you in the past 20 minutes that we have volumetry, which is essentially a solved problem on stationary research data and also in clinical real life. We have AI as a catalysator in the multimodal fusion of structural MRI and PET. We have the hybrid PET MRI where AI has made a lot of advances, like the deep learning attenuation correction and so on. And also the most important conceptual shift is that we move now from diagnosis to prognosis with models like sustained, generative, subtyping, and connectivity based. Thank you very much for your attention, and I will be happy to answer questions at the end.